Good afternoon. The topic of my study was multifocal electroretinogram changes in hydroxychloroquine users. There is no financial interest. Hydroxychloroquine is a disease-modifying anti-rheumatic drug used for treatment of autoimmune diseases, and its toxicity is characterized by bilateral bullseye maculopathy, and it leads to irreversible loss of visual function even after the drug has been stopped. The mechanism of the toxicity is that it gets accumulated in the retinal pigment epithelial cells, leading to progressive outer retinal toxicity, resulting in RPE and photoreceptor cell death, eventually leading to secondary vision loss. Multifocal electroretinogram is an objective method to detect localized retinal abnormalities by Sutter in 1992. And our study focuses on MFERG changes in HCQ users and its significance in early detection of drug toxicity in patients reporting to a tertiary care center in South India. Aim of the study to evaluate the changes of MFERG in patients on HCQ treatment and to correlate with other subjective and objective tests in detecting early toxicity. Materials and methodology: it was a retrospective cross-sectional study done from the period June 2021 to June 2022. After obtaining demographic details of the patient, the following were recorded, which included dosage and duration of HCQ, visual acuity, SDOCT, 10-2 and 30-2 automated visual field, fundus photograph, and MFERG. And statistical analysis were done, and a p-value of less than 0.05 were considered to be significant. And the results were: the mean age was 53.12 plus or minus 15.3 years, and the majority of patients were above 45 years of age. And HCQ dosage: 6 patients out of 50 patients were exposed to a total HCQ dose greater than 1000 grams, and an average daily dose of HCQ was 200 mg in 45 patients, 300 mg in 1 patient, and 400 mg in 4 patients. Majority of patients took treatment for less than or equal to 5 years, and 3 patients received treatment for less than 1 year duration, and 1 patient received HCQ for more than 20 years. On visual field analysis, 10-2 fields, it was normal in 44 patients and toxicity was detected in 6 patients. And in 30-2 fields, normal visual fields was there in 35 patients and toxicity was detected in 15 patients. MFERG was normal in 31 patients and abnormal in 19 patients. And patients with MFERG abnormality, the most common abnormality was parafoveal depression, which included 16 patients, followed by generalized depression, which included 3 patients. And this was the picture showing parafoveal depression and generalized depression in MFERG. OCT and fundus autofluorescence, there was no gross abnormality detected in our patients. Coming to discussion, MFERG changes mostly in the form of parafoveal depression was detected in 19 subjects, similar to that reported by Sang et al. And there was no statistically significant association between dose of hydroxychloroquine or duration of treatment with MFERG changes. And MFERG changes in patients with normal visual fields. 10-2 fields were normal in 44 patients, and among these 44 patients, 9 patients showed MFERG changes, indicating early toxicity that was not detected by the 10-2 fields. And 30-2 fields were normal in 35 patients, in which 4 patients showed changes in MFERG, indicating early toxicity not detected by 30-2 fields. Importance of a wider field testing. Visual field defects were detected more often in the 30-2 fields compared to 10-2 fields, and this is consistent with the reported data on Asian eyes exhibiting more peripheral field defects, which goes undetected on performing a 10-2 field alone, and this underlines the importance of performing 24-2 or 30-2 fields in our population. MFERG detecting early toxicity. In our series, 4 patients with MFERG changes did not exhibit any visual field defect. Though both visual fields and MFERG are objective tests which detect functional changes, MFERG is highly sensitive and can detect very early changes even before the appearance of field test. Conclusion: MFERG detects early toxicity in clinically symptomatic and asymptomatic patients on long-term HCQ therapy. Even patients with normal visual acuity, normal fundus, and normal visual fields can have abnormal ERG changes. And central visual field testing of 10-2 along with 30-2 is useful in detecting HCQ toxicity in Asian population. And MFERG emerged to be one of the objective tests for early detection and follow-up of eyes with suspected toxicity. These were my references. Thank you.
Good study, Minna. I just wanted to know what is the kind of visual field defect you had detected, and was there any correlation with the defect?
Visual field defects were mostly paracentral defects and few parafoveal defects also.
So did you do any kind of a correlation with those defects with MFERG?
Uh,
Maybe you have not presented, that's why I asked you.
Actually, we didn't do that.
Okay, another
Correlation.
thing is, do you recommend to get an MFERG, like based on your study before starting an HCQ?
It can be included as as a
Or
screening
just
test.
a field test is better?
Field test, in our study, 4 patients had MFERG toxicity, those who did not show field defect. So, MFERG definitely detects toxicity earlier. So, more studies have to come to conclude that MFERG is doing better than visual field. Ours is a retrospective study.
Yeah, that's all. Thank you.
One last question. You said that 24-2 or 30-2 picked up more changes than the 10-2. Were there any patients who were not picked up in 24-2 that were picked up in 10-2?
No, sir.
No. Then why do a 10-2 at all? Is your recommendation that we stop doing 10-2 for all these patients?
10-2 has been recommended according to the American American Ophthalmology guidelines. But in Asian population, peripheral field defects are more common than central field.
You ruled out these peripheral field defects from other causes, I assume.
Yes, sir. Thank you.
Good afternoon, all of you. My topic is a cross-sectional study on the prevalence of ocular surface risk factors in microbial keratitis. As we all know, the corneal ulcer is the second most common cause of blindness. About 1.5 million cases of corneal blindness is being reported annually, of which 9% of the cases are from India. So it is a cause of high ocular mobility and is a cause of silent pandemic. To effectively prevent this, a proper understanding of the risk factors is necessary. The objective of my study, primary, to determine the prevalence of ocular surface risk factors in microbial keratitis, secondary, to determine the microbiological profile of these corneal ulcer cases. Materials and methods, study design. It is a hospital-based cross-sectional study done in a tertiary care center in South India, and the study population included patients with corneal ulcer satisfying the inclusion criteria presenting at a tertiary care center. The sample size was calculated to be 90. My inclusion criteria were patients of the age group 18 to 70 years and patients with unilateral corneal ulcer, and the exclusion criteria were one-eyed patients, bilateral corneal ulcer, viral corneal ulcer, Hansen's disease, history of chronic use of any eye drops, mentally challenged or uncooperative patients, and corneal dystrophies and degenerations. Study variables included demographic data, history of ocular trauma and ocular surgery, history of contact lens wear use, then slit lamp examination to look for adnexal diseases like meibomitis and blepharitis, lid disparities like trichiasis, corneal sensation was tested, and dry eye evaluation. Data collection technique. Patients with unilateral corneal ulcer satisfying the inclusion criteria were selected, and their demographic data and detailed history was taken. On slit lamp examination, characteristic of the ulcer, details of the adnexal examination, and corneal sensation was tested. And dry eye evaluation was done, and the microbiological profile of these corneal ulcer patients were done, and the data was analyzed. The results were, most common age group was 61 to 70 year of age, and the male 64% of them belonged to were males, and the occupation was 45% of them were agricultural workers and 65% rural population. History of trauma was present in about 68% of the patients, and most common was vegetative matter, 40%. History of contact lens wear use was found in 8.9%, and decreased corneal sensation was found in 40% of the patients. Type of surgery, corneal surgery was present in 3.3% of the patients, and dry eye evaluation found out to be dry eye was present in 28% of the patients. In the next and lid disorders, meibomitis was found in 26.7%, which was maximum, followed by blepharitis 4%, and in the lid disorders, trichiasis was maximum 4%, and lag of ophthalmos 3.3%. In the microbiological profile of the patients, most of them were staphylococcus, that is bacterial keratitis 13.3%, and among the fungus, fusarium was maximum 11%. Discussion. In my study, the history of trauma was the main ocular surface risk factor present in 68% of the patient, which was similar to my parents' study, Sachin et al. And Bhavna et al. 42%. And in my study, 31% of patients had adnexal diseases and 8.3 had lid abnormality, which was more than that in my parents' study, Sachin et al., which was 10%, and Bhavna et al., 11%. And dry eye was present in 28% of the patients, which was also similar to the study by Bhavna et al. Decreased corneal sensation was found in 40% of the patient. The strength of the study was the sampling was done in a tertiary care center, and the weakness is that there is no follow-up data to look for prognosis of these cases. Conclusion: ocular trauma, decreased corneal secretion, and sensation and adnexal diseases are important risk factors for development of corneal ulcer. Ocular surface diseases, which are usually overlooked, accounts for increased burden of the disease. Treating these accompanying factors can drastically improve the prognosis of each case. These were my references. Thank you. Thank you.
Good presentation, Doctor. In your exclusion criteria, you have said viral.
Yes,
now,
madam.
on what basis you've said like,
Madam,
it's a viral?
I was testing the corneal sensation was being tested. So, in viral keratitis, sensation will be decreased. So, I don't want.
But then your study also shows that 40% decreased corneal sensation. So you're contradicting your statements.
The
no?
corneal.
Because 40%, if I
Yes.
see it right, 40% was sterile. You didn't get any organisms from your corneal ulcer
No,
profiling.
viral was
No?
excluded.
Okay.
So what ma'am is trying to say is you excluded viral, you excluded Hansen's. Then how do you account for 40% of the patients having decreased corneal sensation? What do you think was happening there? Because the main causes you've ruled out and you've excluded from your study. So we don't have any viral ulcer patients in your study group. So what accounts for this 40% decreased sensation?
Because of maybe comorbidities, diabetes. Or,
And the next question is that did you find any association between any, you said mebobinitis and other things were there,
Mebobinitis.
and the organisms that were found in those patients, were they organisms that is found in the normal?
normal. Most of them were
Congenital flora, was there?
staphylococcus.
Thank you.
Thank you.
Good afternoon, everyone. The topic that I'll be presenting today is on efficacy of adalimumab in the control of pediatric non-infectious uveitis. So, the background and the rationale behind my study is that pediatric non-infectious uveitis is an asymptomatic sight-threatening disease. First line of management for it is corticosteroid along with other immunosuppressants like methotrexate plus minus MMF. However, a significant proportion of these patients remain refractory to the treatment. The pro-inflammatory cytokine, that is tumor necrosis factor alpha, is thought to play a key role. Adalimumab, a recombinant human immunoglobulin Ig1 monoclonal antibody that specifically binds to tumor necrosis factor alpha, is the only systemic biological agent currently approved for the treatment of non-infectious uveitis. And despite this FDA approval, there is a paucity of the data on the ocular outcomes in the pediatric non-infectious uveitis in the real world scenario. And that is why the objective of my study was to see the effect and the efficacy of adalimumab in a real world population, focusing primarily on the changes in best-corrected visual acuity and its steroid sparing effect. Also, during the study, I assessed the drug retention rate on the basis of rate of discontinuation due to inefficacy, loss of efficacy, side effects, or ocular remission. Material and method, it was a prospective observational study and it spanned over a time period of 1.5 years. All pediatric non-infectious uveitis patients on treatment at our hospital who were refractory to traditional treatment of multi-drug regime, who were started on adalimumab standard dose by a pediatric rheumatologist, were included in the study, and the study setting was Department of Ophthalmology at a tertiary care center. Sample size, so based on an existing literature and with the power of 80% and 95% confidence, the minimum sample size that I came to was 7. Exclusion criteria in my study was the age of the patient being less than 2 years were not included. Patient who were too sick to cooperate with ophthalmic evaluation were not included. Patient who cannot be followed up due to other reasons were not included, and patient who have already been on any biologics before were not included. So methodology included checking their visual acuity using Snellen's and a thorough anterior segment as well as posterior segment examination. Coming to a few definitions, refractory uveitis, active inflammation and inactive inflammation is as per the Sun criteria. The treatment failure, which I took up from Raman and et al. Study, was treatment failure was defined as recurrence of ocular inflammation at least one eye as follows: 3 plus anterior chamber activity at any single visit, more than 0.5 anterior chamber cells for persisting for more than 28 days, 2-step increase in anterior chamber cell activity noticed 2 separate visits apart, or 0.5 vitreous haze, active retinal or choroidal inflammation or macular edema that was observed at 2 separate visits. So demographics of my study. In my study, 43% of the patients were male and 57% of them were females. Results, as per the anatomical classification of uveitis, anterior uveitis was about 55% of the patients, followed by posterior uveitis, intermediate uveitis and panuveitis. Etiology, as collaborating with the other studies that have already been done, JIA stands still to be the most primary reason for causing pediatric non-infectious uveitis in my study also, with 57%, followed by uveitis secondary to Blau syndrome, secondary to Behçet's disease, and chronic anterior idiopathic uveitis. So in this chart, what I basically wanted to show you is that the visual acuity was preserved throughout the study period for majority of our patient, and if it worsened, it was just one step decrease, that is from 6.6 to 6.9. Response of ocular inflammation in adalimumab to adalimumab, that is what I am comparing, is the mean ACA activity at the baseline as well as 1 year. Majority of our patients were better off at the end of 1 year. If you see the mean number of steroidal drops per eye per day that were recorded at the baseline as well as at 12 months, you see a downward trends which is promising. The two outliers that we can see here, one is having post-op inflammation and the other patient was discontinued treatment for 4 months. Systemic steroid trends over the last 1 year during my study. You can see that the systemic steroids were tapered off drastically for 85% of the patients was off systemic steroids, and the outlier here again was using the steroids at the end of the 1 year. Discussion. Our observation was that the effectiveness of adalimumab was demonstrated by the reduction of active inflammation at the 1 year mark and by the achievement of oral steroid-free remission in 85% of my population, and 72% patients were off steroidal eye drops. None of our patients during our study period reached treatment failure. Sample size in our study was low, but when compared to other studies which were mostly retrospective and multicentric, our prospective single center based study is showing similar results, supports the notion of adalimumab being an effective and safe in long-term control of ocular inflammation. These are the two other studies that I am comparing my study with, and as you can see, all of these studies are retrospective, or if it is prospective, it is multi-center, and our steroid-free remission rates were comparable with them. Limitation of my study would be limited sample size. Concluding remark would be that adalimumab is effective in controlling ocular inflammation, delaying treatment failure, and has beneficial steroid sparing effect as seen in our cases. The dosing regimen and the side effect profile of adalimumab works in favor of the patients, as the compliance is good, and as shown in our study where 85% of the subjects were compliant to adalimumab. Moving on, the way ahead would be to have larger prospective studies to formulate a protocol for adalimumab administration in pediatric non-infectious uveitis patient. Also, I would request NGOs and government schemes to be implemented in order to provide this drug to the deserving patients suffering from pediatric non-infectious uveitis that would give them a chance to fight against this sight-threatening disease. Thank you.
I think it's a great study, good presentation as well. And one thing which I wanted to ask, you said the vision came down to 6, I mean, if at all it come down to 6.9. I think that's a little risky statement considering a pediatric population.
Yes.
Did you do an OCT in any of these patients?
Only when required, ma'am. Whenever there was a clinical sign of macular edema.
So do you think, because we are not sure about the adalimumab side effects on ocular side effects, thing. So probably an OCT also I feel that should be included, because 6.6 to 6.9 is also significant in
yes,
when you consider.
It was well collaborated with the cataract test change.
Okay, cataract test change, but I think that was not coming out in your results. Thank you.
And you had 7 patients. What were the ages? Do you know?
The age was from 5 years to 18 years, mean being 9.7 years.
Okay, so all of them could cooperate on the Snellen's chart
Snellen's, yes.
because all of them
Yes,
were
yes,
measured
yeah.
on that. Okay, why did you choose children and not any adults specifically? Any reason?
Because pediatric non-infectious uveitis is primarily a white type of inflammation, and these if these people are not followed up regularly, then we might end up losing the vision, and the patients usually present late. Fortunately, at our institute, because of their other problems like swelling in the knee joint or any other issues, they present to us earlier, and from the rheumatology side, they refer to our retina clinic and uvea clinic.
Yeah, and last question, what was the dosage and what is the cost?
Okay, adalimumab is 24,000 rupees per injection, and that is why it is very costly for the patient. And the dosage is under 30 kgs, it is given as 20 milligram, and for the adult dose, it is 40 milligram. And it is a subcutaneous injection given bi-monthly. Twice in a month. So the total dose per month would be 48,000.
Thank you.
Thank you.
Good afternoon, everyone. I am here to present my paper, a cross-sectional study of dry eye disease in diabetic patients at a tertiary care center in Kerala. Diabetes is considered as the global diabetic capital, and the Lancet study has said that there is a 4-fold increase in diabetics across the world, and among the 5 countries, India is one which contributes to half of this population. Diabetic retinopathy is considered as one of the leading causes of blindness in 20 to 70-year-olds. Dry eye disease is present globally in 6 to 34% of the population, and recently, dry eye disease has been increasingly reported in diabetics, affecting their quality of life. There is no gold standard model to determine dry eye disease severity, and its association with diabetic retinopathy is not well described, and studies on the same are sparse in our area. Hence, the relevance of the study to understand about the complications of diabetic retinopathy, its association with dry eye disease. We have aimed to find the prevalence of dry eye disease and its severity in diabetics, and also to find a correlation between diabetic dry eye disease and diabetic retinopathy and between their severities. This was a cross-sectional study including all previously diagnosed diabetics in our ophthalmology department of our tertiary care center of 203 patients determined by Devi RSU et al. Over a period of 1 year. We have excluded any patients who have underwent ocular surgery, who are contact lens users, who have local or systemic diseases known to cause dry eye disease or medications known to cause dry eye disease, and pregnant women. We have collected our data after written informed consent. We have taken a comprehensive history, and after ophthalmological examination, we have assessed dry eye disease subjectively using the OSDI, which is the Ocular Surface Disease Index questionnaire, and graded accordingly, and also objectively assessed for the tear functions using the Schimmer's 1 test and the tear film breakup time. Dry eye disease was diagnosed and severity graded after the average values of taken, and diabetic retinopathy was graded according to the ETDRS classification. Data so obtained was entered in the MS Excel and analyzed using the IBM SPSS software, and considered statistically significant if probability value was less than 0.05. Coming to the results. This is the distribution of our study. The bar graph shows that the mean age of the population was at 56.02 years, and we had a majority of the study population was males at 58%. We have found that the mean of the study population of duration of diabetes was at 8.81 years. We have found that 60% of the study population was affected with dry eye disease. Distribution in the dry eye disease in the study population showed that most frequency of dry eye disease affected were within the age group of 51 to 60 years. And we have found that there was a female preponderance in dry eye disease, but though it was insignificant statistically. Both age and duration of diabetes was statistically significant with the dry eye disease. This shows the comparison between the subjective and objective assessments of dry eye disease, which shows that by OSDI score, there was 49 people who were symptomatic. This is the grading of dry eye disease. We had seen a majority of those affected with mild dry eye disease. Proportion of diabetic retinopathy, we had found the prevalence of diabetic retinopathy within the population was 53.2, and most had moderate NPDR. Distribution of diabetic retinopathy was found significant with age and duration of diabetes, but insignificant with the gender. There was a significant increase in occurrence of diabetic retinopathy with age. 52% were males and 55 females. So this is the association of dry eye disease with diabetic retinopathy, and we have found that it was at 44% and statistically significant. The associations of both severities of dry eye disease and diabetic retinopathy was also found significant statistically. Coming to the discussion, our study had a prevalence of 60%, which was a little less than the prevalence observed in the parent study. And we have found that the other studies had a lower prevalence of dry eye disease, unlike Sushilo Jeha et al., which showed a prevalence of dry eye disease at 76%. Our ages, mean age of the study groups were comparable to other studies. And all studies that I have analyzed with association of dry eye disease and gender was found insignificant statistically, though we had a female preponderance. Duration of diabetes was found lower, and that was at 8.81. Prevalence at diabetic retinopathy was also lower at 53%, unlike 70% at Manwith et al. Most studies correlated dry eye disease and diabetic retinopathy statistically significant factors, and including the severities of dry eye disease and diabetic retinopathy was also statistically significant when compared to Knepp et al. So we come to a conclusion that there is a significant prevalence of dry eye disease in diabetics, and it has the severity of diabetic retinopathy and diabetic retinopathy and dry eye disease paralleled with each other, which we can see that routinely we have to screen diabetics for dry eye disease as well, especially those affected with diabetic retinopathy. Some limitations of a study are absence of control group, small sample size. Larger sample size are required to elucidate a better relationship with dry eye disease and diabetic retinopathy. These are my references. Thank you.
Anu, thank you for your study and for explaining it. I have just one question. Here we were trying to see if diabetic retinopathy or prolonged duration of diabetes and the relation with dry eye disease. So very good. One thing that you have masked in your study is that mild, moderate, severe NPDR as well as PDR, you say, the figures showed that all of them, about 50% of them only had dry eye disease. What I'm trying to ask is, will the severity of diabetic retinopathy affect dry eye disease in any way?
Since both have a microvasculopathy involved, it can be assumed that or come to a conclusion that because microvasculopathy is involved in both diseases, they can be a confounding factor as well as a causal relationship. But we will need prospective studies to rule out that diabetic retinopathy is a cause for dry eye disease and to associate a proper severity.
What I'm asking is worsening of diabetic retinopathy and dry eye disease.
Yes, sir. It has. From my study, it was significant.
Do you think a treatment can change this, this incidence?
Incidence, we'll have, yes,
control,
because I think we have to control diabetics actually, the diabetic glycemic status, which in turn is the root cause of every complication of diabetes. So like that, probably we'll be able to, but there are many confounding factors like the age of the patient, if they are diabetic, the duration of diabetes. So many of the confounding factors do come into play, but we can aim to decrease the incidence of dry eye disease.
Thank you.
Thank you, ma'am.
Good afternoon. I am presenting clinical risk factors and treatment outcome of neovascular glaucoma in a tertiary eye care center, a prospective descriptive study. Neovascular glaucoma is a secondary glaucoma due to proliferation of fibrovascular tissue with progressive closure of angle of anterior chamber, also known as rubeotic glaucoma, congestive, thrombotic, hemorrhagic or 100-day glaucoma. The most common etiology is proliferative diabetic retinopathy followed by central retinal vein occlusion and ocular ischemic syndrome. Chronic retinal ischemia leads to release of angiogenic factors which results in neovascularization of iris and angle and subsequently neovascular glaucoma. It progresses through a pre-rubiotic stage, rubiosis iridis, secondary open angle and angle closure glaucoma. So the aim of our study was to determine the causes of neovascular glaucoma and to study our treatment protocol and their outcome in cases of neovascular glaucoma. So here, in patients with visual acuity better than 1/60 and an open angle were treated with anti-glaucoma medication, intravitreal anti-VEGF, pan-retinal photocoagulation, and if the IOP was not controlled, they underwent glaucoma filtration surgeries. Those with a closed angle underwent medical management along with surgical management. Those with visual acuity less than 1/60 and with no pain, they were observed, and with pain underwent cyclodestructive procedures. Ours was a prospective descriptive study and was done between November 2020 to October 2021. Patients with an intraocular pressure of more than 21 millimeter mercury and neovascularization of iris or angle were included. All patients with primary angle closure glaucoma or other secondary glaucoma were excluded. A comprehensive evaluation was done and the management was based on our treatment protocol. The response to treatment were monitored, visual acuity, anterior and posterior segment examination, IOP and gonioscopy were recorded during each visit. The final visual outcome and IOP were recorded. Results. 36 eyes of 36 patients with NVG were enrolled, which included 20 males and 16 females. Majority of them belonged to 7th decade. The major systemic associate was diabetes mellitus followed by systemic hypertension. The most common etiology was proliferative diabetic retinopathy, which constituted 61%, followed by retinal vein occlusion, which constituted 31%. Visual acuity at presentation was worse than 1.3 for majority of the study population, and this was because most of the patients presented at an advanced stage. Most of the patients presented with an intraocular pressure in the range of 21 to 30 millimeter mercury. Most of the patients were already on anti-glaucoma medication at presentation. A higher initial IOP was noted in angle closure group. Majority of the patients were in angle closure glaucoma stage at presentation. They were managed with topical anti-glaucoma medication, oral carbonic anhydrase inhibitor. 33% underwent surgery, 78% underwent pan-retinal photocoagulation. The rest of the patients were already lasered. 69% underwent intravitreal anti-VEGF injection and 5% cyclocryotherapy. And coming to the surgical management, 7 eyes underwent trabeculectomy with mitomycin C and 2 underwent Ahmed glaucoma valve implantation. 3 patients who developed painful blind eye had to undergo evisceration as they developed corneal ulcer. Most of the patients achieved a final good IOP control following therapy, and the IOP control was much better in open angle group compared to angle closure. The mean number of drugs used initially for IOP control was 2.58, which got reduced to 1.56 following therapy. On comparing the initial and final visual acuity, there was no significant improvement or deterioration was noted following the therapy in either groups. And on comparing patients with proliferative diabetic retinopathy and central retinal vein occlusion, there was no statistically significant difference was noted between final IOP and visual acuity. So the commonest etiology was diabetic retinopathy and followed by central retinal vein occlusion, which was similar to the previous studies. Most of the patients were in angle closure glaucoma stage, and in our study, the final IOP of less than or equal to 21 millimeter mercury was obtained in 85% in open angle and 63% in angle closure. According to Satoko Nakano et al., angle closure was found to have the greatest effect on NVG IOP prognosis. In our study, 7 eyes underwent trabeculectomy with mitomycin C and 2 eyes underwent Ahmed glaucoma valve implantation, and all of them had good IOP control. According to Takihara et al., trabeculectomy with mitomycin C for IOP lowering in NVG eyes had a success rate of 62% at 1 year, and according to Azad et al., successful control of IOP ranging from 22 to 97% were obtained with GDD. According to Maldivius et al., improvement in visual acuity was seen only in 7 to 20% eyes, while majority had no change in BCVA or deteriorated. To conclude, NVG neovascular glaucoma is a refractory type of secondary glaucoma, the commonest etiology being diabetic retinopathy followed by retinal vein occlusion. Majority of the patients present at an advanced stage. The visual acuity doesn't show much improvement despite of the various treatment modalities, but early diagnosis, timely management and an adequate IOP control can help to prevent further progression and helps to maintain visual acuity. These are my references. Thank you.
Good, Dr. Sajana. Since you have said treatment outcomes, I would like to know the gap between your anti-VEGF injection and when did you take up for say TRAB or AGV, and were these procedures combined with an anti-VEGF injection?
It varied for different patients, ma'am. Actually, we had a total follow-up of 6 months, and some patients were already had started on anti-VEGF. They had been referred from some other place, so it varied with each patient.
Yeah, so that also sometimes matters, like, you know, when you are taking up, and now more and more studies are coming up with anti-VEGF along with your anti-glaucoma surgery. So when you say the treatment outcome, all probably all sorts of treatment for glaucoma also should be included.
Sajana, two more questions very quickly. You said that 3 patients had an illustration. I'm assuming that was for a painful blind eye.
Yes, sir.
Was cyclocryo offered for them?
Yes, sir. Out of the 3 patients, initially 2 patients underwent cyclocryotherapy, and subsequently they had to undergo evisceration.
Okay. And one other question is that in your treatment modalities, you mentioned 4 or 5 modalities. But many a time we use more than one modality on one patient. So how did you decide which group to fit the patient in? Because it exactly totaled up to 100. It was like as though each patient had only one treatment modality.
Like based on the vision and the stage of presentation, we'll start on the therapy, and depending upon the response, we modify the therapy according to our treatment protocol.
How did you decide where to put them into which group?
Like if the patient was presenting in an open angle stage and with an IOP elevated, we'll start on anti-glaucoma medication, and at the same time we'll go for a panretinal photocoagulation, aggressive PRP and anti-VEGF injections, and we'll look for the control. And if the patient was not better on this, we'll go for a glaucoma filtration surgery, and initially we'll go for trabeculectomy, and if there was failure, then we'll go for a glaucoma drainage device like Ahmed glaucoma valve implantation.
You completely omit prostaglandins in all these patients?
Yes, ma'am. We didn't give any prostaglandin as there is more chance of inflammation. It worsens the condition, so we have not given prostaglandins. Thank you.
Good afternoon. My topic is post-refractive surgery dry eye, a comparative study on microkeratom LASIK versus femtosecond LASIK versus transepithelial photorefractive keratectomy. I have no financial interest. LASIK is a corneal refractive surgery with a critical step of flap creation followed by surface ablation, and in our study we used M2 Moria microkeratom for the creation of flap with an average thickness of 110 micrometer, and in femtosecond laser we used FS200 violet which creates a flap thickness of average 100 micrometer. And surface ablation transepithelial photorefractive keratectomy, it is a one-step removal of epithelium and stroma which has no instrument contact with cornea, and there is no flap. We are using Shintamari 750S for the procedure. Post-LASIK dry eye hypothesis. Since the cornea is a densely innervated tissue, during the flap creation in LASIK procedure, there will be transection of the afferent sensory nerves in the anterior third of the stroma, which severs both subbasal and subepithelial nerve plexus all around the flap except at the hinge. Whereas in trans-PRK, there will be no such transection because of the absence of flap. In addition to there will be the dryness is also contributed by the flap thickness, suction introduced in the creation of flap, and stromal dehydration. And also decreased corneal sensitivity, which in turn leads to decreased meibomian gland secretion and decreased blink rate, which in turn increases the tear evaporation and decreased tear secretion. Dry eyes are the primary reason for patient dissatisfaction after LASIK surgery. By this study, there have been studies comparing the incidence of dry eye between microkeratom and femtosecond LASIK, whereas no studies are available comparing these 3 procedures. Since trans-PRK is a flapless procedure, theoretically, it has a less propensity for post-refractive surgery dry eye compared to the flap-based procedures. Hence, our study is to compare the incidence and pattern of dry eye disease among 3 types of refractive surgery. Our study is a prospective study conducted in our study from December 2022 to March 2022, included 108 eyes with 36 eyes from each group. We included dry eye questionnaire, DEQ5 and SANDI2 questionnaire, and dry eye parameters are analyzed using IDRA, which included non-invasive tear film breakup time, meniscal height, lipid layer thickness, meibomian gland loss area, and eye blink quality, which are assessed during pre-op and also during post-operative follow-up visits up to 6 months. Coming to the result, In our study, we noted all the dry eye parameters showed a similar pattern in all the three procedures during the follow-up visits. That is, there is a significant reduction from baseline at both third and sixth postoperative month in all the dry eye parameters. And also, we noted a maximum reduction at the third postoperative month in all the procedures. We also noted a better value in the trans-PRK group compared to the other two groups. Mebabian gland loss area also showed a similar trend, and Schirmer 1 and 2 show significant reduction in the Schirmer value from baseline to 6th postoperative month and with a better value in the trans-PRK group. We compared DQ5 and SAND2 questionnaire, and we noted high symptom score in trans-PRK group at the first postoperative day, whereas in other two groups we noted a significant high symptom score in the first and third postoperative month. And we got a similar result with DQ5 and SAND2, even though the SAND has only 2 questions. By analyzing all these, we reached that a dry eye at third postoperative month in standard group is 25 eyes, which is reduced to 14 eyes by 6th postoperative month, whereas in femto it was 21, which is reduced to 11 by 6th postoperative month, whereas in trans-PRK it was 15 eyes by third postoperative month, which is reduced to 5 eyes by 6th postoperative month. Coming to the discussion, we noted post-LASIK dry eye. Cavo et al. Noted chronic post-LASIK dry eye at 6th postoperative month. By comparing tear volume, tear film breakup time, it was about 22 to 40%. Shoja MR et al. Noted post-LASIK dry eye at 6th postoperative month by comparing tear beauty and Schirmer value, which was about 20%. In our study, we compared microkeratome, femto and trans-PRK by analyzing dry eye questionnaire and IDRA parameters, which was about 14 to 40%. Elma Bisovic et al. Compared femto and microkeratome. They noted decreased Schirmer test and TI-BUT, and they noted a better value in the femto second group and no difference after 12 months of surgery. Saeed Ikra Iqbal et al. Compared trans-PRK and tear film stability. They noted a significant reduction in the TI-BUT and Schirmer in the trans-PRK. In our study, we also got a similar result, that is significant reduction in both all the dry eye parameters in all the 3 procedures with a better value in the trans-PRK. Chinson et al. Compared OSDA in microkeratome and femto, and they got a better value in the femto second group. In our study, we compared microkeratome, femto and trans-PRK by analyzing DQ5 and SAND2. We also got a high symptom score in all the procedures with a better value in trans-PRK. Coming to the conclusion, we noted a lesser incidence of dry eye in trans-PRK when compared to other 2 groups, with a higher incidence at third postoperative month. All the dry eye parameters were better in the trans-PRK group, and the postoperative dry eye was predominantly an evaporative dry eye. Even though the SAND2 has only 2 questions, we got a similar result with the DQ5, hence it will be a more easier practical alternative to DQ5. These are my references. Thank you.
As such, how long it takes, I mean, as you know, the refractive surgeries does cause dryness, and they give long-term lubricating drops. So
in our hospital, we are giving 3-month lubricant drops. Following after that, only if the patient is symptomatic, we are giving the lubricants.
So this study you said prospective or
prospective study.
So after 3 months of, this was with lubricating drops?
With lubricating drops.
So after stopping the lubricating drops, have you checked whether, it's symptomatic? Probably some people may or may not be.
Actually it was less, even after even without drops, the patient's symptoms is less compared to the third postoperative month.
Okay. So you have not gone beyond that?
Not, only up to 6 months.
So all groups are getting the same amount of lubricating drops?
Yes, yes, sir.
So one important thing which I'm sure you would have done but you forgot to mention is, I'm assuming all of them were age and sex matched.
Yes, sir. All of them are sex
should have been mentioned because it makes such a difference for dry eye disease.
Yes,
Good.
thanks.
Good afternoon. Topic is clinical profile of patients with ethambutol optic neuropathy. No financial interest. Ethambutol is used in treatment of infections.
Excuse me, doctor, you can remove your mask and speak probably.
Ethambutol is used in treatment of infections caused by mycobacterium species, including tuberculosis. An important and well-reported side effect of the drug is toxic optic neuropathy, which, if not picked up early, can result in variable and often significant visual function loss. Significance. Why this study? RNDCP initially adopted twice-weekly regimen for treatment of drug-sensitive TB. The revised RNDCP guidelines 2016 has extended the use of ethambutol from initial 2-month intensive phase to remaining 4 months of continuation phase, as well as shifted from alternative day regimen to daily regimen. The continuation phase in both new and previously treated cases may be extended by 12 to 24 weeks in certain forms of TB like CNS, skeletal, and disseminated TB. Aim to describe the clinical profile of patients with ethambutol optic neuropathy from a tertiary eye hospital. The materials and method. This is a retrospective observational study conducted from October 2020 to June 2022. 32 eyes of 16 patients with ethambutol optic neuropathy were studied. The parameters used are best corrected visual acuity, color vision, contrast sensitivity, HFA, pattern VEP, flash VEP, and OCT RNFL. The symptoms. Majority of patients presented with the complaints of defective vision within 2 to 3 weeks of onset of symptom. Mostly in the last 2 months of ATT treatment. 5 patients presented just after the completion of treatment. A patient who received prolonged ATT for bone TB presented with a defective vision after 14 months of treatment. Coming to the results. Most of the patients included an age group of more than 60 years. No sex predisposition noted. Most of the patients included an extraprimary group. Coming to vision comparison in initial and final visit, the BCV in dogma during follow-up showed a marginal improvement from 0.8 to 0.65. The observed difference was not statistically significant. The p-value was noted to be 0.141. HFA or octopus field analysis done in all patients except 3 due to poor vision. Most of the patients presented with the centrocecal scotoma. 20% presented with the bitemporal field defect. We also done MRI to rule out neurological causes such as compressive lesion. In 2 patients, thinning of optic nerve and chiasma seen. In 1 patient, mild to moderate cerebral atrophy with thinning of optic nerve noted. Improvement field in only in 2 patients after stopping the offending drug. The color vision was abnormal in majority of the patients, normal in patients with the vision 6/9 or better. OCT RNFL was normal in 82%. 2 patients showed thickening of RNFL in superior and inferior quadrant. 1 patient showed temporal thinning. Coming to disc evaluation, it was normal in 69%, disc pallor in 18%, hyperemic disc in 11%, disc hemorrhages in 2%. 36% of normal discs presented as temporal pallor on follow-up visit. VEP done in all patients, flash VEP done in patient with vision less than or equal to 636. Pattern VEP done in 5 patients. 3 patients had normal latency with reduced amplitude. 2 patients showed additional prolongation of P100 with a decreased amplitude. Flash VEP done in 11 patients. 7 patients showed prolongation of P2 with reduced N2 P2 amplitude. 4 patients shows abnormal indistinguishable waveforms. This is the right and left field analysis. Same patient's flash VEP showing prolonged P2 and relatively normal amplitude. The treatment advised was ethambutol was stopped in almost all patients and continues on rifampicin and isoniazid. Neurovitamins were also supplemented. Coming to the discussion part. Most of the patients who manifested ethambutol toxicity was elderly patients over 60 years. Extrapulmonary TB was prominent, which would have necessitated prolonged or extended therapy, adding to the risk. The study conducted by Pragati Garg et al. is a prospective study of ocular toxicity in patients receiving ethambutol as a part of previous guidelines noted that change in visual acuity from 0.26 to 0.04, the p-value was less than 0.001, which was statistically significant. The similar study conducted by Menon et al., a prospective evaluation of visual function for early detection of ethambutol toxicity based on previous guidelines noted that vision improved in almost all patients after stoppage of the drug. But in our study, based on revised RNDCP guidelines, change in visual acuity from 0.8 to 0.65, the p-value was 0.141, which was not statistically significant. HFA field analysis showed centrocecal scotoma in most of the patients. VEP, pattern or flash, was found to be affected in most patients similar to visual field, thus making this investigation most useful in picking up early toxicity. The OCT RNFL was normal in majority of the patient initial visit and therefore not useful in detecting toxicity. Disc appearance can be normal, hyperemic, or sometimes with peripapular hemorrhages or mild temporal pallor. In our series, 36% of those with normal disc at presentation subsequently developed temporal pallor on follow-up, indicating ongoing optic atrophy. So the point is, ethambutol toxicity is a cause of potentially permanent vision loss and need to be addressed in current scenario of longer duration of its use under new treatment guidelines of India. Even after stopping drug, vision acuity did not improve significantly in our case series. Disc appearance, which was normal initially, on follow-up showed temporal pallor, which showed ongoing optic atrophy. PEP, pattern or flash, was found to be affected in most patients, thus making it most practical in picking up early toxicity. The limitation of the study, this is a retrospective study, small sample size, simultaneous intake of isoniazid and linezolid not taken into consideration. These are my references. Thank you.
Thank you, Archa. Nice study. I have just two questions for you. One is that did you look at the weight of the patient and take that into consideration as to the reason being, you know what I'm talking about. Even though ethambutol has been increased, the RNTPC guidelines are all weight segments. So someone at the lower end of the segment and higher end of the segment, there's totally different dosage going in. So did you find any difference like that in your study based on the weight?
No, sir, we gave 20 milligram per kilogram body weight for all patients.
But that's not what RNTPC does. They don't follow 20 milligram per body weight. They give according to weight groups. So people in one weight group will get the same dose, irrespective if where they fall in that weight group. So that could have been looked at. And one last question. You never mentioned anything about how long it took? Was there a dose dependent thing as how much of dosage of drug led to it? Did you look at any of those parameters in your study? As in how long after ethambutol was started did they develop?
We followed up with the patients for 6 months.
Yeah, no, based on how long of taking ethambutol they presented with ethambutol toxicity. You did not look at that in your study?
After 2 months. Most of the patients presented with after 2 months of the treatment.
Okay.
So you started your study when the patient approached you with some problem.
Yes, ma'am.
So then, again, we cannot say that after how many months this toxicity has started, because they have approached you. Some people might approach you earlier, some people might approach you later. So probably I think you could connect with the, general pulmonologist or something to take it up before, so that you understand how frequent you should do the follow-up, so that you pick up the ethambutol toxicity even earlier, because your study shows that there is an ongoing process in spite of stopping the drug. That's scary. So, patient is losing out.
Thank you.